All right, this is a quick overview of the study guide that I posted in week 12 of your Blackboard folder on cardiovascular system. So we have Alex and Taylor here to help us do a little review for our class. So we let class lab out a little earlier, then decided that, wait a minute, we could spend that extra time reviewing for the test. So that's why we're here. So number one, what metabolic pathway do heart muscle cells use for energy? What do you think?
Krebs and disease.
Yes, because it needs oxygen, right? It does not do well with the lactic acid fermentation. So the Krebs and the electron transport chain are the ones that use oxygen. And we know that because what do muscle cells have a lot of for these processes to occur in? Mitochondria, yep. Number two, how do the left and right ventricles differ in pressure and or volume? So pressure, which side is the high pressure side?
That'd be the left.
The left, yep. The left is the high pressure side. What about volume?
They're the same.
They're the same, correct. Left and right ventricles have the same volume, but the left endures higher pressure. And how do we know that? If we look at the structure of the left ventricle?
The greater muscle thickness.
Yep, thicker outer wall on that left ventricle. All right, so number three looks at the cardiac action potential. Do you remember what channels drift slowly open to bring pacemaker cells to thresholds? We're talking the SA node, AV node, all that. What channels open to drift them toward threshold? And then we see the big spike.
That'd be calcium.
Nope, calcium is the rapid depolarization. The drifting is
Potassium.
That's the repolarization.
Okay. So the
Sodium.
Sodium, yep, sodium channels in the AV-SA node drift towards threshold. Then they spike up with that calcium. So what specific channels open to create the upward spike in those cells then? Did we just say? Calcium. And letter C, what specific channels cause the plateau phase in cardiac contractile cells? So these are the 99% of muscle cells.
potassium.
The plateau, so we have sodium bringing it up, and look at your action potentials for the contractile cells. This is the 99%.
Calcium.
Calcium, yep, causes the plateau. So 3A and 3B are talking about the pacemaker potential, which is the 1% of cells that never has a resting. And then letter C is talking about the contractile cells that do have a resting potential until the pacemaker cells give it that action potential through the gap junctions. All right, number four, what specific areas in the heart are pacemaker cells?
The AV and SA node.
SA node, AV node, what else?
Purkinje fibers.
Purkinje fibers, bundle of His,
Bundle branches.
bundle branches, yep, all of those. So they're the ones that are going to have that pacemaker potential in your PowerPoint that never has a flat line. It always drifts and then spikes up, comes down, drifts up, spikes up, comes down.
What is that? I think I had.
What?
Oh.
Bundle of this.
Number five, what is the effect of parasympathetic stimulation on the heart? Do you remember where are those fibers from the vagus nerve? So
Slows down the heart rate.
slows the heart rate. So
SA node.
and the AV node as well. Yeah.
So
So letter B, what is the name of the parasympathetic nerves that influence the heart? That's the vagus nerves coming on either side of the brainstem.
the SA node fires at 100 times per minute.
On its own,
On its
naturally.
own, and then parasympathetic brings it down to 75.
Yeah.
Okay.
Puts the brakes on to down to 75.
Let's say you have a heart transplant.
Right, yeah. So parasympathetic nerves are the vagus nerves, letter B. And number five, parasympathetic stimulation slows the heart rate. What are the major effects of sympathetic stimulation on the heart? So what does the sympathetic nervous system do to the heart?
Speeds of
Increases.
Increases the heart rate. What else does it do to those muscle cells? Remember that those sympathetic fibers contract on the muscle cells themselves and increase the squeeze. Yeah, contractility. Increases contractility, and it affects the vasculature, the coronary arteries. What do you think it does? Yeah, dilates the coronary arteries. So that's actually 3. But on the heart itself, it's contractility, increases the squeeze, and increases the rate. What special structures are associated with those AV valves, and what is their function?
Chordate tendon.
Yep, chordate tendineae, and what do they prevent?
Backflow.
Backflow. Yep, they keep those valves shut tight and not flipping up into the atria, like those sprockets that you see are brackets on an umbrella. Keeps it from flipping upward in the wind, even though that does still do. Yeah, depending on the quality of your umbrella.
Yeah.
Yeah. So name the features of cardiac muscle cells compared to skeletal and smooth.
Intercalated discs.
Intercalated discs. And what do we find at intercalated discs?
Desmosomes and gap junction.
Yep, very good. Desmosomes tether the cells together. Gap junctions are doorways between the cells for ions to flow. So action potentials can flow throughout the cells without needing to generate one on their own, unless it's a pacemaker cell.
And
More mitochondria,
Yes.
already mentioned that. And is it striated or non-striated?
Striated.
Striated. And how about the nuclei? Do we have multiple nuclei like skeletal or single nuclei?
single.
Single. Are they tapered cells, cylindrical cells, or branched cells?
They're long.
They're not as long and cylindrical like skeletal muscle cells, so they're branched.
They're branched.
They're a little shorter and branched because they're just making up that heart. They have troponin. They need calcium, sodium, potassium, just like skeletal muscle cells. So during what specific phases of the cardiac cycle are the first and second heart sounds heard? So the first heart sound, the lub, is the shutting of what valves?
The ventricle. The AV.
Yeah, the AV valves. So what causes them to shut? What's happening?
The
The start of
systole.
ventricular ejection phase, or the start of, or that period is known as the just the beginning of the isovolumetric contraction phase.
So how
So,
would I write that?
The beginning of the isovolumetric contraction phase. IVC is how you abbreviate that phase of the cycle. IVC. And then the second heart sound, the DUP, is right at the beginning of the other isovolumic phase, at the beginning of the isovolumic, because it's backflow on the
Relaxing.
aortic valve and the pulmonary valve. Yeah, so that's when the ventricles are relaxing. Isovolumic relaxation phase. Okay, so essentially, just remember the first heart sound is when the ventricles are starting to contract, and the second heart sound is when the ventricles are starting to relax. And both of those occur at the IVC for the first one and the IVR for the second. Know the order of phases beginning with ventricular filling. So is ventricular filling, does it start actively or passively?
Starts passive.
Yep, so we have ventricular filling passive, followed by ventricular filling active, when the atria contract and actively fill the rest of the ventricle. Then we have that brief phase that's isovolumetric. And which one is that? So we have passive filling, active filling, isovolumetric.
Might be active since it's contracting.
Well, I'm not asking if it's active or
Oh.
passive, but contracting. So it's isovolumetric contraction phase, where the heart is a completely closed chamber. All the valves are closed at this point. Then what comes after that when the pulmonary and aortic valve open? So we have passive filling, active filling, isovolumetric contraction phase. Then is the
Contraction.
ejection.
Ejection.
We call it the ejection phase. Then the heart relaxes, so then we have the isovolumetric relaxation phase. So we have, starting at the beginning, we have passive filling, active filling, isovolumetric contraction, ejection. Now we're isovolumetric relaxation phase.
So, hold on. So one is active, no, passive.
And then we have the whole process starting over again, right? So just remember those first four and you're good to go, right?
What is the third and fourth one?
Or did I say five?
Third is
I'm going to start from the beginning
parasympathetic.
so our listeners online can get this straight. Passive ventricular filling, so passive filling, then active filling, then isovolumetric contraction phase, then ejection as the ventricles eject their blood from the heart, then isovolumetric relaxation, and then the whole process starts over again. So remember those in that order, and then it just repeats. That's why it's a cycle, right? Okay, how much fluid leaves the capillaries at the arterial end, venule end, and how much enters the lymphatics per day? Do you remember that?
Arterial is
Is 10.
10.
And at the venule end,
Negative 8.
Negative 8.
those are pressures.
Oh,
So we're looking at volumes here.
Oh,
You might need to
so
look back at your
it's,
PowerPoint.
16, no, 26.
$20 liters leaves, if you look at the handout I gave, this one, we zero in this corner, it says 20 liters leaves the arterial end, and on the venule end, 17 re-enters. So how much is entering these lymphatics here? 20 leaves, 17 enters, again. So how much stays in the tissues then?
17 leaves the venue.
about 3.
Yep, 3 liters enters the lymphatics. And those lymphatics, if you remember from the quiz you took, goes back to the vascular system up top by the subclavian vein. So, about 3 liters enter the lymphatics per day. So if the SA node fails, how will the AV node respond?
Picks up.
It would take over the heart rate, right? And what would the rate be? Do you remember what I gave you for a value of the AV node?
It's about 60.
Take a look at your, I don't have
Isn't
it
it 30?
written. No, that's down below. Yeah, yeah, yeah. It's over by the pacemaker. Yeah, 60 sounds right. The rate is actually 50 beats per minute, and that's what's shown in number 12 here is 50 beats per minute. If the SA node fails and the AV node has to take over, the AV fires action potentials at a rate of 50 beats per minute. So what are some dietary factors that would increase blood pressure, causing increasing blood volume, increasing blood pressure, and making the heart work harder to pump to pump blood? So what did we say? If you have heart failure, we want to tell those patients to limit their fluid intake, so less fluid intake. And what else pulls fluid into the vessels? Anytime,
Solutes.
yeah, what specific solute do we get too much of in the American diet?
Sodium.
Sodium, yeah. So we want to limit salt, limit fluid. What is unique about the isovolumetric contraction and relaxation phase?
All the valves are closed.
All the valves are closed. Is blood entering or leaving during that time?
No.
No. So volume is unchanging and all the valves are closed. So what vessels carry oxygenated blood to our heart muscle cells?
So,
The
coronary arteries.
Yep, left and right coronary arteries. And number 16, we'll talk about the ones to the heart muscle cells first. So oxygenated blood comes left and right coronary arteries. And where do those vessels start?
Base of the aorta.
Yep, base of the aorta. And then carrying blood from the heart muscle cells back to the heart.
coronary veins. Or cardiac veins.
Cardiac veins. And specifically, what's that large collecting vessel?
Cardiac
Sorry.
sinus.
Coronary sinus. The coronary sinus, and that ends at so the coronary sinus delivers blood from the cardiac veins to what part of the heart? Correct, the right atrium. So the coronary sinus carries deoxygenated blood from the heart muscle cells to the right atrium. That's where they end, is the right atrium. So coronary sinus is number 15, the from part, coronary sinus, and the end part is right atrium. The two should be left and right coronary arteries, and where they start is at the base of the aorta. Okay. Where does the sympathetic nervous system act on the heart? We already mentioned that. SAAB node, cardiac contractile cells, and if we're looking at the blood vessels, the coronary arteries.
Cardiac,
Contractile cells, yeah. So what are baroreceptors? What kind of receptors are they testing? What are they testing, sensing?
Pressure.
Pressure, yeah. And where are they found?
Aorta, carotid arteries.
Yep, and the walls of the atria. So aorta, carotid arteries, and walls of the atria. We find baroreceptors, which detect pressure. So carotid arteries and aorta are the major controllers of blood pressure. And then the other one I just talked about, the atria, those kick in when pressure is increased. The other ones fire when pressure is decreased. Okay, the formula for calculating cardiac output and stroke volume. So the formula for cardiac output is CO equals HR times SV. And how do we calculate stroke volume? We have to know the volume in the heart before it contracts and after contracts. Do you remember those two numbers?
EDV and
Yeah.
ESV.
Yep. EDV minus ESV. The volume before it and systolic. And diastolic is what's in the heart when it's relaxed before it pumps, and then what's left over after it pumps is ESV. What factors influence blood pressure, vessel diameter, blood volume, etc.? So what factors? What are the vessels doing for high blood pressure?
constricting.
Constricting. What's the blood volume if we have high blood pressure? High.
I guess a big factor that would influence blood pressure is how much fluid you have.
Mm-hmm. Yep. So blood volume is high for high blood pressure. All right, 4 pressures acting on the capillary bed. I don't think we need to go through those all specifically because we have, again, this handout that lists them all, so you can do that on your own, because just look at that table and you can answer that question. So we'll skip that one. What are some factors that would cause edema? What would cause an increase in fluids leaking out of the capillary?
Hydrostatic pressure.
Congestive heart failure.
Mm-hmm. So too much hydrostatic pressure?
Right-sided congestive heart failure.
Yes. Because it backs up into the inferior and superior vena cava and causes fluid to leak out of those capillaries. But you don't have to know right-sided versus left-sided heart failure. That's definitely a nursing concept. So, increased capillary hydrostatic pressure, which would be high blood pressure, right? Also, if you have less protein in the blood, less albumin, there's less suck into the capillary. Would you agree? Less osmotic suck into the capillary, so fluids leak out. So low capillary osmotic pressure would cause fluid to leak out. Structural and functional differences between arteries and veins. Which has the higher diameter? Larger diameter. Veins are larger in diameter. Which has the thicker muscular wall?
Arteries.
Arteries, thicker muscular wall. Which has valves?
Veins.
Veins. Those are the major differences. Another one, which has higher pressure?
Arteries.
Arteries, because of that thick muscular wall. Veins are low pressure vessels. definitions for this, these are right out of your notes. You can go in and just copy those directly out of your notes. Don't go to the book. Use the notes, use the definition they gave you in your PowerPoint. Just remember venous return though. What are some things that increase venous return?
Deep breathing.
Deep breathing.
Muscle movement.
Muscle movement.
That's all I got.
That's pretty much it. I think that's what we talked about, right? That was, I think it's in there.
I didn't write it down.
Okay. Remember the terms preload, afterload, and contractility? So preload is the amount of stretch in the heart, and that is determined by venous return, isn't it? So venous return, influences preload. And then afterload is the pressure the heart has to endure to overcome and empty the heart. Well, not completely empty, but eject its blood. So blood pressure affects afterload, and contractility is just the amount of squeeze, right? The strength of squeeze. So that's not on the study guide, but do know the definitions of those and what would increase or decrease it in the body. So afterload, preload, and contractility. Know the definitions and what would increase or decrease it. All right, that's it. Looking at the action potential graphs for pacemaker and cardiac, and be able to label the different ions, right? So I'll just show you those quick so everybody is on the same page. Graph represents what type of cells? Contractile cells. 99% of the cells in the heart have this. So what causes this upward rapid spike? What ion here?
No,
Sodium. And then right at the tip is when potassium channels open, but then it doesn't drop right away because of the plateau, which is caused by calcium, and then those eventually shut, and then potassium can finish the job, right? So potassium starts the drop, but it's prevented from dropping much because of calcium here, and then potassium finishes up. All right, and then we have the other type, which is this guy, which is a pacemaker cell. So we have this drifting upward to threshold before we see the rapid spike. The drifting upward is caused by sodium. Once it reaches threshold, this rapid spike up is caused by calcium, and then the decline again, potassium. Yep, and then it drifts back up due to sodium. Okay, so just be able to identify those two action potentials. And I think that concludes the review.